Welcome everyone. In today's video, we are going to talk about periprosthetic fractures in total hip replacement. These fractures can occur on the femoral side or on the acetabular side. Femoral fractures are more common. Periprosthetic fractures may be intraoperative or postoperative. The risk factors for periprosthetic fractures are female sex, elderly patients, post-traumatic osteoarthritis, inflammatory arthritis, a complex bony deformity of the proximal femur, osteoporosis, and revision surgery. Now let us talk about intraoperative femoral fractures. These are more common in cementless THA compared to cemented THA, with incidence as high as 5.4% in primary THA and 21% in revision THA. These numbers are for cementless THA. Now, these fractures can occur at various stages of the surgery. During dislocation, the fragile bone, as in a osteoporosis, may fracture due to excessive rotational force if it is applied without adequate soft tissue release like a capsular release. Again, in a condition like protrusio, osteophytes may form around the femoral head in the acetabular rim. If these osteophytes are not resected and a rotational force is applied, fracture may occur. One method is to take an in situ net cut in these cases and remove the femoral head piecemeal to avoid these fractures. Another step in which fractures can occur is broaching or femoral component insertion. Now, broaches are not designed to remove cortical endosteal bone. So, if cortical endosteal bone is not removed and broaching is done, this may cause fracture. So before we start broaching, we have to use a reamer, straight or flexible, to remove this cortical endosteal bone to prevent these fractures from occurring. Another condition in which we have to be careful while broaching is an altered proximal femoral anatomy, which may also be susceptible to fracture during broaching. Now let us have a look at the classification of intraoperative femoral fractures. The classification is a modification of the Vancouver classification. There are three types: A, B, and C. A occurs in the proximal metaphysis, B occurs in the proximal diaphysis, and C occurs in the distal metaphysis. In type B, it is amenable to a long stem fixation, and in type C, the fracture has to extend beyond the longest femoral stem available, that is, it is not amenable to a long stem fixation. Each of these types are further divided into three subtypes. One is perforation, two is an undisplaced fracture, and three is a displaced fracture. So now we are left with 9 types: A1, A2, A3, B1, B2, B3, and C1, C2, C3. So A1 fracture is a perforation of the proximal metaphysis, and the treatment is a morselized bone graft, usually obtained from acetabular reaming. In A2, there is an undisplaced fracture of the proximal metaphysis, and the treatment is cerclage wiring. Now, this cerclage wiring is usually done before inserting the final stem to prevent crack propagation. A3 type is a displaced fracture of the proximal metaphysis. Here we have to use a diaphysial fitting stem that fits in the diaphysis plus cerclage. In isolated GT fractures or greater trochanteric fractures, these can be fixed with wires, cables, and a claw pad retaining the original stem. Type B fractures are fractures of the proximal diaphysis which are amenable to long stem fixation. Type B1 is a perforation. Here we have to see whether the perforation is proximal to the stem tip or not. If it is proximal, we do a morselized bone grafting alone. If it is distal to the stem tip, then we have to see whether the stem is stable or not. In a stable stem, we can do a cerclage with a allograft strut. However, if the stem is not stable, we have to use a longer stem and cerclage with a allograft strut. In type B2, there is an undisplaced fracture of the diaphysis, and again we have to see whether the stem is stable or not. In a stable stem, we do a cerclage. In an unstable stem, we have to see whether the bone stock is adequate or not. If the bone stock is adequate, we just do a longer stem and cerclage. If the bone stock is inadequate, along with the long stem, we have to add a cerclage using a allograft strut. In type B3, this is a displaced fracture. So again we have to see if the stem is stable or not. If it is stable, we do a cerclage with a allograft strut. If the stem is not stable, we have to replace the stem with a longer stem and do a allograft strut cerclage. So any of these type B, if the stem is not stable, we have to change the stem. Type C involves the distal metaphysis and is not amenable to a long stem fixation. So in C1 there is a perforation and the treatment is a morselized bone graft. In C2 there is an undisplaced fracture, so a cerclage with a allograft strut. And in type C3 it's a displaced fracture, we have to do a open reduction and internal fixation. Now coming to postoperative femoral fractures. These are less common than intraoperative fractures. This may be caused due to stress fractures, which is caused by increased use of the limb after surgery, or stress risers, which may occur due to cortical defects during surgery or the implants used in the surgery. And the third cause is trauma, which is severe enough to even fracture a normal limb. The risk factors for postoperative femoral fractures are osteoporosis, compromised bone stock, cementless prosthesis, revision total hip arthroplasty. These are similar to the risk factors for preoperative femoral fractures. The additional risk factors are stem loosening and osteolysis and heterotrophic ossification. Now what this heterotrophic ossification does is that it increases the stress transfer to the proximal femur because the range of motion at the hip is reduced and is a predisposing factor for postoperative femoral fractures. Now let us see the classification of postoperative femoral fractures. This is also the Vancouver classification, which divides these fractures into three types: A, B and C. A involves the trochanteric region, B occurs around or just distal to the stem tip, and C occurs well below the stem tip. A is further divided into AG involving the greater trochanter or AL involving the lesser trochanter. B has three subtypes: B1 in which the prosthesis is stable, B2 in which the prosthesis is unstable, and B3 in which there is inadequate bone stock. Coming to the treatment, in type A, it is mostly stable and the treatment is protected weight bearing for around 6 weeks. If the greater trochanteric fracture is displaced, trochanteric fixation is done. In lesser trochanteric fracture, surgery is only indicated if it involves the medial cortex, causing instability of the stem. In type B1, the stem is well fixed. The fracture occurs around or just distal to the tip and the stem is well fixed. And the treatment is open reduction and internal fixation, and a rigid fixation is recommended. The recommended system are cable plate systems. Now these have options for both screws and cables. Now this fixation can be supplemented with a allograft strut. In B2 type, the stem is loose, so we have to change the stem. Whenever the stem is loose, we have to change the stem, and revision with a long stem has to be performed. Now this can be a cemented long stem or an uncemented long stem. In cemented long stem, there are chances of cement extrusion. So before inserting this, the fracture has to be reduced and has to be held in place with some bone clamp or wires so that this cement extrusion can be prevented. In uncemented fixation, porous coated stems with distal flutes are preferred. This may be supplemented with allograft strut grafting. In type B3, there is a deficient bone stock in the proximal femur and is not suitable for either ORIF or a new stem. And the options are allograft prosthesis complex or APC or proximal femoral prosthesis. In type C, the fracture is well below the stem and generally the stem is well fixed and the treatment is an open reduction and internal fixation with a rigid fixation. Now let us talk about acetabular fractures. Now periprosthetic acetabular fractures are extremely rare. They may be intraoperative and postoperative. Intraoperative occur in around 0.4% of the cases and almost all of them are associated with an uncemented prosthesis. They are further divided into three types. First type is undisplaced and stable and no specific treatment is required. Type 2 is undisplaced and potentially unstable. Here a different prosthesis has to be used with multiple screw holes which allow supplemental fixation. And in type 3 it is displaced and unstable and here the acetabulum has to be fixed first. The posterior column may be fixed with a plate, anterior column may be fixed with a lag screw, and after that we assess the stability of the fracture. If the fracture is stable, then an uncemented cup with additional screws may be used, and if the fracture is still not stable, an anti-protrusio cage with a cemented cup may be used. Postoperative acetabular fractures are extremely rare and may be associated with a significant trauma. In undisplaced cases, a protected weight bearing of 6 weeks is used and a displaced acetabular fracture is managed with reconstruction similar to type 3 of intraoperative acetabular fractures. So friends, in this video we discussed periprosthetic fractures in total hip arthroplasty. If you like these videos, please hit the like button and subscribe to the channel for further videos. Also, comment in the comment section regarding the topics you will like to be covered in the future videos. Thank you.